speaker, Francesca Mora. Francesca is obviously, you've heard from her already this morning. Here she is. And we had a great lecture on the basically the anatomy and using transvaginal ultrasound. And I think it'll become a bit clearer now why, knowing the anatomy is so important when you come to evaluate particularly cervical cancer. I think cervical cancer obviously is a big issue as a bigger issue in some countries more than others, and I think particularly relevant for this particular meeting, and also where perhaps cross-sectional imaging and so on isn't necessarily available. And so the use of ultrasound is something which I think is something which I hope everyone finds very interesting. So Francesca is going to talk about evaluating cervical cancer, and then after that we're going to have an MDT. Over to you, Francesca.
The evaluation of cervical cancer using ultrasound. In the last 20 years, we have focused on the study of cervical cancer and ultrasound examination. We first explore how to visualize the cervical lesion and cervical tumor, then how to stage the disease, and then we have explored the role of ultrasound-guided biopsy. And finally, we are exploring the role of artificial intelligence and radiomics applied to ultrasound imaging in gynecological cancer patients. Many studies have been published on ultrasound and cervical cancer. It has been established that the accuracy, sensitivity, and specificity of ultrasound examination when performed by an expert are similar to MRI regarding tumor detection, but also the evaluation of parametrial infiltration. This is a video showing a normal cervix, anterior lip, posterior lip, and cervical canal. This is another image showing normal cervix. Again, anterior lip, posterior lip, cervical canal. What about this one? This is another image showing a cervix, but with a small tumor. Cervical tumor can be hypoechoic, isoechoic, or hyperechoic, and it usually richly vascularized at color Doppler examination. After the detection of the tumor in the cervix, we can assess fertility-sparing criteria, including tumor size, depth of stromal invasion, and the distance between the cranial tumor margin and internal os. Fertility-sparing treatment is possible when the lesion is equal or less than 2 centimeters. It's possible when the depth of stromal invasion is less than 2/3, and also when the distance between the cranial tumor margin and the internal uterine os is more than 1 centimeter. It's possible when the lymph node status is negative, and it's important also to obtain adequate free margins of the cervix, and also preservation of the upper part of the cervix. According to the recently published guidelines, patients with cervical cancer with squamous cell carcinomas or HPV-associated usual type adenocarcinoma are candidate to fertility-sparing surgery when the lymph nodes are negative and the tumor size is equal or less than 2 centimeters. For tumor between 2 and 4 centimeters, fertility-sparing treatment can be considered, but in selected cases. We can also use ultrasound examination in the follow-up. It is not recommended in the guidelines, but in my institution, we also used ultrasound examination during follow-up. We can stage the disease, we can assess the spread of disease in these patients with ultrasound examination. So after the evaluation of the cervix and the cervical cancer, and after the examination of the fertility spelling criteria, we can assess parametria, rectovaginal septum, vesicovaginal septum, bladder, rectum, hydronephrosis, and lymph nodes. In this scheme, I just summarize how can we assess with transvaginal ultrasound examination regarding parametria. In particular, at the level of the vagina, we can assess the septum, the vesicovaginal septum between bladder and vagina, and posteriorly, we can assess the rectovaginal septum between vagina and rectum. At the level of the cervix, we can assess the right and left vesicouterine ligaments between bladder and cervix, corresponding to the anterior parametrium. We can also assess the structure between cervix and pelvic side wall, corresponding to the lateral parametrium, and posteriorly, we can assess the ligaments between cervix and rectum. In this video, we can recognize a large cervical tumor infiltrating bladder. And we can observe that the vesicovaginal septum is fixed, is obliterated. This is another video showing a large cervical tumor infiltrating the bladder and also the parametrium on the left and also on the right side. This is another video showing a large cervical tumor infiltrating the rectovaginal septum. This is the rectum, this is the vaginal wall, and this is the tumor infiltrating the rectovaginal septum. With transabdominal ultrasound examination, we can assess kidneys and the presence of hydronephrosis, and also we can assess the presence of pelvic lymph nodes and the lymph nodes in the abdomen. Daniela Fischerova and David Sibula demonstrated that when performed by an expert, ultrasound examination can be considered a sufficient diagnostic tool for the assessment of macrometastasis. So the sensitivity and the specificity of the ultrasound examination when performed by an expert was similar to that of other imaging methods such as MRI and CT scan. We also assess the role of ultrasound examination in predicting response after neoadjuvant treatment with chemoradiation. We perform a study comparing ultrasound, MRI, and PET-CT performed before, during, and after treatment to assess pathological response. We assess also 3D parameters and contrast parameters with ultrasound examination, but up to now, there is no parameters with high accuracy, sensitivity, and specificity able to discriminate between patients with a complete response and those without response. We also explore fusion imaging in locally advanced cervical cancer patients. The fusion is a method using contemporarily two techniques. For example, in this case, we can have MRI and ultrasound contemporarily. In this image, we can visualize a tumor on MRI on the left side, and ultrasound and the lesion on ultrasound examination the right side. It was just a feasibility study, but we need to explore more to better understand its role in cervical cancer patients. As I told you before, we can use ultrasound examination during follow-up of patients with cervical cancer. In particular, in this young lady with the previous cervical cancer, I identified a tumor, a recurrence in the pelvis. And during the examination, I also performed the true-cut biopsy to obtain a specimen for the histology. So it's quite easy to perform a transvaginal biopsy. We can just need the transvaginal probe, the needle, and the biopsy system. And the presence of recurrence is one of the indications for true-cut biopsy. Finally, artificial intelligence and radiomics. So, in the last few years, some authors explored the role of artificial intelligence in cervical cancer, and they, in particular, try to explore its role in the detection of lymph node metastases. But at the moment, the results are not clear. We are also exploring the radiomics applied to ultrasound imaging in advanced cervical cancer patients in order to predict the response to radiochemotherapy. I would like to conclude my presentation with a clinical case, 51-year-old lady with previous myomectomy. She was nulliparous. The pap smear test was positive, and also the cervical biopsy was positive for carcinoma. This was our ultrasound examination. So in this image, we can identify the uterus, cervix, endometrium, which was thin. What do you think about this cervix? So we can we can visualize very well the cervix in this section, but using the real zoom, we can assess the cervix, and also we can visualize a small lesion in the anterior and the posterior lip. It was also richly vascularized at the color Doppler examination. This is the lesion in the transversal section, and it was richly vascularized. Both ovaries were normal. This is the colposcopy showing the lesion. So the stage was 1B1, and the patient was included in this international multi-center randomized control trial. And therefore, she underwent a robotic surgery, and a radical hysterectomy, bilateral salpingo-oophorectomy, and bilateral pelvic lymphadenectomy were performed. This is the macroscopy. We can identify the end adenomyosis. This was the right parametrium. This was the left parametrium, normal. And this is the lesion on ultrasound examination, and finally at macroscopy. So this was my presentation. I would like just to summarizing that we can use ultrasound examination to assess patients with the cervical cancer. We can also stage the disease. We can follow up this lady with ultrasound examination. We can take the biopsy during the examination. And finally, we want to explore also the role of artificial intelligence and radiomic to improve the diagnosis and management of these patients. And thank you very much for your attention.
Thank you so much, Francesca, for this very detailed presentation. I am fascinated by how much ultrasound scan can really do for cervical cancer. This is very, very unusual in the UK for us to assess with cervical cancer. I'm trying really to push on that, but there is, as you know, lots of obstacles, especially with all the technologies we have. But it's really great to see that you can stage, you can assess for fertility preserving surgery, you can choose your patients. That's really amazing. I just wanted to ask, you know, the echogenicity of the cancer, how important it is, you know, to assess if it is low echogenicity, hyper echogenicity. Do you really look into that? Can the cancer, the squamous cell be different than the adenocarcinoma? Is this anything like that?
Yeah. Okay. So thank you very much. I don't think it's very important so to distinguish between an hypoechoic lesion, hyperechoic or isoechoic. Elizabeth so described that usually squamous carcinoma as more frequently hypoechoic, whereas adenocarcinoma are more isoechoic, hyperechoic. But there is no other important so features or findings related to the echo structure. Usually, the cervical cancer is more frequently hypoechoic because the squamous stuff is more frequently, in particular the H related, and the typical characteristics is the vascularization because it was richly vascularized. That's the reason because it's important to use the real zoom to check the cervix, anterior, posterior lip, cervical canal, and then use the color to check if there are some small lesion, probably not detectable, not visible without color. I think the color in this type of patients help a lot.
Excellent. Do you still have to resort to other imaging to help after you do your ultrasound scan? Do you still order CT scan to see, or ultrasound scan is enough for fertility preserving?
Is in my institution, so we use ultrasound examination, but there is also radiologists working on that in particular or MRI. So we can use ultrasound and or MRI.
I see. So you do the ultrasound, but do you still do some imaging after, or you
Yeah,
say?
we do it still, not in all cases, but in most cases we still do it also further imaging, in particular MRI. I think it's dependent from the hospital and of the, for example, because in Gemelli Hospital, the radiologist department is very big, so
I know.
have a key role in particular also in the management of gynecological patients, and that's also the reason because we still.
But from your opinion, do you think it's needed? Do you think if you do an ultrasound scan and you're very happy with the quality of the ultrasound scan and your assessment, you think this is 1B1, you can see a very small tumor there, you're very confident, parametrium is free, ureter is free, the kidney, you've done abdominal scan, you've checked the lymph nodes, and you think, are you still confident to go ahead with just without MRI?
Yeah, I'm confident just to do ultrasound examination and not asking any more imaging. So there is also Daniela. She's an expert on that, and I think she agrees with me. So
can I just interject? I mean, I think you've done some teaching of this, haven't you, in Africa, haven't you, or Antonia, on cervical cancer and ultrasound, Francesca, or was Antonia went there as well? Have you found much uptake of that, or have I got that wrong?
Yeah, probably Antonia.
Okay, right. I wondered if you had as well. Yeah. No, but it's interesting to have the confidence. I always think it's sort of to have the confidence to say there's no extension, and therefore you can do a conservative approach. Do you agree, Ahmed? I mean,
absolutely. I mean, this is
the
amazing.
thing, isn't it?
Yeah, it's really Very good.
There's a question from the audience, which is just technical. It says, what is VCI, Francesca?
Sorry?
What is VCI from the... And did you say that in your talk? Did you talk about...
No.
No. Oh dear, sorry. In that case...
I think it was a question for Mala, probably.
Okay, not to worry.
Okay.
Don't worry about that. Marla, what's VCI since you're there?
It's volume contrast imaging. So it adds a thin slice to your rendered image and makes the margins very clear, much more clearer. So we use it to assess myometrial invasion.
Perfect. Okay. So I think this is a good time because we're gonna, I mean, Francesca, you're staying with us, and so I think we should try and give as much time to the MDT discussion as possible, I think, because then I think these things tend to come together quite nicely. So